Welcome back to The Deep Dive. We're the show that helps you navigate through complex source material. And today, we're tackling something really critical. It's about disease X, that placeholder name for whatever the next big pandemic pathogen turns out to be.
Yeah, and look, this isn't just some academic thought experiment. The sources we looked at are really clear. The world was, frankly, caught flat-footed by SARS-CoV-2. The initial response, yes, there was innovation later, but at first it was pretty much a massive, chaotic scramble.
Exactly. Which brings us straight to the core question you wanted us to dig into. When that next crisis inevitably hits, where should our focus be? Our resources, they're huge, but they're finite. Do we pour everything into the R&D side, developing new treatments, tests, vaccines, that really long, really expensive road? Or do we need to pivot? Should the immediate priority be on strategies like decentralized detection, isolation, getting ahead of the spread with intelligent triage before it blows up?
That's the fundamental tension, isn't it? The sort of long-term, high-stakes promise of maybe finding a cure or a vaccine versus the immediate, maybe more scalable power of just containing the thing. Now, R&D, obviously, it's crucial for global health security in the long run. We need innovation, but we absolutely have to look hard at the lessons from COVID-19 and be realistic about the challenges, the limitations, the sheer time it takes to develop these countermeasures safely.
Okay, let's unpack that. Our mission today is really to understand why a system focused on rapid, decentralized detection. And we'll look at AI tools like Dr. Maya as an example, why that might actually be our most effective first move, especially when you consider the risk of rushing R&D and this other huge looming crisis, antimicrobial resistance, AMR. So let's start with that traditional path, R&D. The big promise, right? If we just invent a vaccine or a drug super fast, problem solved. But the sources, they paint a picture that's, well, a lot slower, way more expensive, and potentially riskier than we might think, especially when things get fast-tracked.
That speed we think we saw with COVID vaccines, it's a bit deceptive. Yes, there's this drive now, this goal for disease X to get a vaccine in 100 days. But experts are saying, hang on, that is a really tall order.
Why? Why is it such a stretch? Because the COVID vaccines did come relatively quickly.
They did, but that speed didn't just happen out of nowhere. It was built on maybe 20 years of groundwork. Research into related viruses, MERS, SARS, and critically, the platform tech like mRNA. The really sobering thing about disease X is we don't know what it is. We can't predict it, which means we probably haven't done that 20 years of homework yet.
So that foundational science might just not be there.
Exactly. That gap could mean years at the start of a response. But even after the science gets going, the journey for any new drug or vaccine, it's tough. It's like a filter. The data shows less than 14% of potential drugs that look good in the lab preclinically actually make it all the way to approval. It's a brutal process.
Less than 14%. Wow. And do those success rates differ depending on the type of medicine?
Oh, absolutely. Hugely different. Think about cancer drugs, oncology, enormous investment, right? But the success rate there is tragically low, like 3.4%.
Only 3.4%.
Yeah. Now, biologics, which is the category that includes vaccines, they do much better. Their approval rate is around 33.4%.
Okay, so vaccines are kind of the star pupil in that group, but even then, 2 out of 3 still fail somewhere along the way.
That's right. And the fundamental problem systemically is that what happens in a petri dish or even in early animal tests, it just gives you a theory. It's a starting point. It absolutely does not guarantee that it's going to work or be safe when you try to scale it up to millions or even billions of people.
And this is exactly where your concerns about accelerated development come into play. The speed needed for COVID meant, well, compressing years of traditional trials. The public health need was obvious, but what did we actually learn about the safety profiles, particularly for the viral vector and the newer mRNA technologies, according to the reviews in our source material?
Okay, so we need to be really careful here and transparent. Separate what's confirmed data from, hypotheses about these newer platforms. Let's start with the viral vector ones, AstraZeneca, Sputnik V, those types. Systematic reviews, they did confirm common side effects, things like fever, fatigue, feeling unwell, muscle aches, generally mild, went away quickly.
Right, the usual suspects. But the real worry was about the rarer, more serious stuff, wasn't it?
Precisely. And the reviews did document those. Rare, yes, sporadic, but potentially life-threatening events. Things like thrombosis with thrombocytopenia, blood clots with low platelets, or capillary leak syndrome. And very tragically, yes, death in a few isolated cases. But we have to stress the scale. The overall rate of serious adverse events was tiny. For AstraZeneca, it was about zero point 0.2 per 1,000 doses. So the scientific consensus documented in the sources is still that for most people during that pandemic, the benefits of vaccination stopping severe illness, stopping death, far outweighed these very small risks.
Okay. But the lingering public concern, and what our sources seem to focus on too, is more about hypothetical long-term issues, especially with the mRNA platform, which was brand new for mass use, and the idea of applying it universally, this one-size-fits-all approach, without knowing about individual biological differences. What's the specific hypothesis the sources raise about that stabilized mRNA molecule?
Yeah, this hypothesis really touches on big questions for future policy. The sources detail this idea, this mechanism,
Hmm.
suggesting that the way the vaccine mRNA is stabilized, it's designed to stick around longer in your cells to make more protein, that persistence could potentially lead to sustained chronic inflammation in the tissues where it ends up.
Sustained inflammation, that's the key, isn't it? Why is that potentially more of a problem than with traditional vaccines, like ones using a killed virus?
Well, the theory is it could create what the sources call a molecular vicious circle. Because the modified mRNA hangs around for longer, it might keep stimulating the body's innate immune system constantly. And if that goes on for a long time, especially in certain tissues, the hypothesis is that it could theoretically cause the body's systems to kind of malfunction.
And what are the potential downstream effects suggested by this hypothesis? What kind of malfunctions are we talking about?
The hypothesis points towards potentially triggering or maybe worsening autoimmune or autoinflammatory diseases, things where the immune system mistakenly attacks the body. And even more concerning, potentially, is the idea that this chronic immune stimulation might eventually lead to genomic instability or mutagenesis changes in the cell's genetic material. The sources explicitly propose that if someone happens to have certain genetic variations, these polymorphisms that we maybe haven't even studied in this context, then this one-size-fits-all mass vaccination approach, it might not actually be a safe strategy for them. It's this unknown combined with the pressure to act fast in a pandemic that really highlights why just banking everything on R&D for a cure is, well, it's a gamble with potentially systemic risks.
Okay, so the road to a proven safe cure or vaccine is long, it's costly, and if you rush it, there are these inherent risks of potential long-term issues for certain people, which logically means we have to shift focus. Containment has to be the immediate priority.
That's the critical pivot, exactly. If the drugs and vaccines are going to be slow, expensive, and carry these kinds of risks, then containment isn't just an option, it's an ethical necessity. And what's really striking here is that the very environment we'd need to manage disease X, our hospitals, our healthcare systems, they're already under strain from another crisis, a silent one almost, antimicrobial resistance, AMR. You really can't think about pandemic preparedness without facing the fact that we are steadily losing our effective antibiotics.
Let's talk about the scale of that AMR crisis, because the numbers are, well, they're pretty staggering when you lay them out.
They really are alarming. Even in wealthier countries, like the OECD nations, the sources say up to 35% of common infections are already resistant to the first drugs doctors would normally reach for. But it gets much, much worse in low and middle income countries, LMICs. There, for some critical antibiotic bug combinations, resistance rates are hitting 80, even 90%.
80 to 90%. That means those drugs are basically useless in those situations.
Pretty much. And it's getting worse. Resistance to our second and third line antibiotics, these are the heavy hitters, the last resort drugs for really serious infections. That resistance is projected to nearly double between 2005 and 2030. So think about that. By the time disease X potentially arrives, our standard medical toolkit could be seriously depleted.
If the drugs are failing, what's driving it? It's not just doctors prescribing too much, is it? There must be more to it.
It's kind of a two-pronged attack, according to the sources. Prong one is definitely the overuse and misuse of antimicrobials in human medicine. Bad prescribing habits, maybe not enough diagnostics, weak rules allowing people to get antibiotics without a prescription in some places. But the second major driver, and this one often flies under the radar, is the absolutely massive use of antimicrobials in agriculture. Not just treating sick animals, but routinely feeding them antibiotics to prevent disease or just make them grow faster. Same with crops sometimes. This creates this enormous constant evolutionary pressure on microbes everywhere, basically breeding resistance on an industrial scale.
And during a pandemic, when people are getting sick, they naturally head to the hospital. But that's precisely where they might be most vulnerable to these superbugs.
Absolutely. The hospital is, without a doubt, the main hotspot for what we call nosocomial infections or hospital-acquired infections, HAIs. And very often these are caused by those multi-drug resistant organisms, MDROs. The danger is huge. The CDC estimates, just in the US, 1.7 million HAIs happen every year, and they contribute to something like 99,000 deaths annually.
99,000 deaths just from infections caught in the hospital. What are the most common types people get?
The data points mainly to two things: catheter-associated urinary tract infections, that's about 32% of cases, and infections at surgical sites, about 22%. When resistant bacteria cause these, they become incredibly difficult, sometimes impossible to treat.
And it's not just bacteria, right? We're seeing new scary fungal threats emerge too, like Candida auris.
Yes, C. auris is a really serious emerging threat. It's a fungus. It's often resistant to multiple antifungal drugs, and it loves the healthcare environment. Controlling it is super tricky. For one thing, standard lab tests often misidentify it, so we don't even have a clear picture of how widespread it is. And we're still not totally sure how it spreads so effectively.
And how does it manage to survive the drugs we do have?
It's got this powerful defense. It forms biofilms. Think of it like a slimy protective shield it creates on surfaces and even inside a patient. This biofilm matrix makes it really hard for antifungal drugs and even the patient's own immune system to get at the fungal cells. And critically, tying it back to pandemics, C. auris infections have been specifically reported in patients who were already seriously ill with COVID-19 complications, so the crises are interconnected.
Okay, this is where things get really weird. The sources point out that some of the things we use to fight these bugs in hospitals might actually be making the resistance problem worse.
That is one of the most counterintuitive findings, yeah. Certain common disinfectants, specifically the ones containing quaternary ammonium compounds, QACs, you see them everywhere, they can accidentally promote resistance, not just to the QACs themselves, but cross-resistance to crucial antibiotics, too.
Hold on, so cleaning stuff is basically training bacteria to beat our medicines. How does that even work at a cellular level?
It's like forced evolution in fast forward. When bacteria are exposed to QACs, it triggers genes inside them that code for something called multi-drug efflux pumps. Imagine the bacterial cell is a tiny submarine. These pumps are like bilge pumps working overtime, actively pumping out toxic stuff, including the QAC disinfectant, but also, crucially, various antibiotics. So by constantly using QACs, we're inadvertently selecting for and strengthening bacteria that are really good at pumping out all sorts of harmful chemicals, making them multi-drug resistant. It increases the risk right there in the hospital.
And even if we get cleaning protocols perfect, there are still these tiny environmental pathways for superbugs that we might be missing entirely.
Yeah, that brings us to insects, often overlooked but potentially significant carriers. The sources highlight things like common houseflies, cockroaches. These insects can act as little shuttles for superbugs, MRSA, VRE, resistant gram-negatives. They can pick them up from contaminated areas like drains or waste bins and then physically transport them to sterile areas like patient rooms or equipment. It's a persistent, low-level transmission route that standard cleaning might just miss.
Okay, so if R&D is risky and slow, and our hospitals are already battling AMR, and even our cleaning might backfire, relying on a future cure seems like a really flawed strategy. This points overwhelmingly towards prevention and containment as the immediate necessary focus. The Swiss cheese model, right?
Exactly. That's the philosophical shift we need. The Swiss cheese model basically says you need multiple layers of defense because no single layer is perfect. Each has holes, like Swiss cheese. We absolutely cannot put all our faith in standard drugs or future vaccines working perfectly. We need backup plans. We need measures that don't rely on getting a specific diagnosis or needing a special test kit or depending on a global supply chain that might break or even needing a pharmacist to give you something. Resilience has to be built in.
So what does that look like in practice? What are these immediate, low-cost, broad-spectrum defenses anyone can use anywhere?
Well, the sources point to several things, some surprisingly simple. Sunlight, for instance. Exposure to sunlight, and specifically near-infrared radiation, NIR, seems to offer strong protection against viruses like influenza. And interestingly, it was correlated with better COVID-19 survival rates, too, and this effect seemed to be independent of vitamin D production, so light itself might have a direct benefit.
Just being outdoors more often. What else?
Fresh air, definitely. And related to that, exposure to what are called phytoncides. These are basically natural compounds released by trees and plants. Breathing them in seems to boost our immune response and reduce inflammation. And then, the absolute fundamentals of health. Moderate daily exercise, making sure you get 7 to 8 hours of good sleep, and eating a whole grain, predominantly plant-based diet.
And is there evidence these basic things actually make a difference against something like a pandemic virus?
Yes, the studies started link these lifestyle factors directly to lower levels of systemic inflammation. And for COVID specifically, they were associated with up to a 4 times lower chance of developing severe disease. It's not magic. It's about optimizing your body's own first line of defense, your innate immune system, so it can handle novel threats more effectively from the get-go.
Okay, let's shift to more conventional public health measures,
Mhm.
non-pharmaceutical interventions, NPIs. You mentioned looking back at older practices.
Yeah, some pre-antibiotic era wisdom might be worth revisiting. Simple things like the cultural habits in some places of taking off street shoes before entering the house, or mandatory hand and foot washing upon entry, basic hygiene barriers, but also more structured practices like what the sources call quarantine mourning.
Quarantine mourning, that sounds intense. What was the idea behind that?
It was essentially a mandatory isolation period for family members after a death in the family. Could last days, sometimes even longer, depending on the culture. The underlying logic was public health. The cause of death might have been an infectious disease. By isolating the immediate family, the community ensured that if anyone else was incubating the illness, they wouldn't spread it during that high-risk period. It prioritized community safety.
Fascinating. Now, thinking about the MPIs we did use widely recently, like masks,
Yeah.
the data on their effectiveness seems really messy, right? Lots of conflicting studies, hard to know what to believe.
That's the huge challenge with evaluating MPIs. Unlike drug trials, you usually can't do a perfect randomized controlled trial, an RCT. You rely on observational data, watching what people do in the real world, and that data is just full of potential biases. People who choose to wear masks might also be doing 10 other things differently, avoiding crowds, washing hands more. It's hard to isolate the effect of the mask itself.
So what did the conflicting studies actually find?
Well, you had meta-analyses, big reviews of multiple studies, suggesting masks offered a modest reduction in transmission risk, maybe in the range of 6% to 15%. But then you also had other studies, like cross-sectional ones, looking at populations at a single point in time, that found, the opposite. One, for example, reported a higher proportion of COVID cases among people who said they consistently wore masks. Another found a higher risk of self-reported respiratory illness in mask wearers.
Wow, that doesn't automatically mean masks don't work, but it sure makes it hard to prove they do work consistently from that kind of data.
Exactly. Even if some of those conflicting findings weren't always statistically significant after adjustments, the fact that you get such contradictory results from observational studies just underscores how difficult it is to get a clear answer on NPI effectiveness compared to, say, a drug trial.
And what about mass testing? That seemed like a cornerstone of containment for a while, and basic screening, like temperature checks.
Mass testing is definitely vital for surveillance. Understanding how much virus is out there, where it's spreading, that informs policy, like when it's safe to lift restrictions. But the sources suggest that its direct containment benefit, just from testing lots of people, might be overstated. The biggest bang for your buck seems to come from targeted testing in high-risk settings, like healthcare workers, rather than just blanket testing everyone.
And those temperature checks at building entrances.
Yeah, those turned out to be largely ineffective. The data show they missed far more cases than they caught. One workplace study cited found they only identified about one infectious person for every 40 they missed. Too many people have no symptoms or can easily mask a fever, so as a reliable screening tool, not really effective.
Okay, so taking all this together, the risks and slowness of R&D, the growing AMR crisis making hospitals less safe, the difficulty in proving and implementing NPIs effectively, it really does force you to think differently. It seems to point towards needing a system that's proactive, immediate, and built on decentralized detection, rather than waiting for the conventional system to react.
That's precisely the argument. We need to address what you could call the triage gap. That critical period, hours or maybe days, when a new threat emerges, symptoms appear, and the normal healthcare system just gets instantly swamped or becomes unreachable for many.
All right, people get scared, they have worrying symptoms, maybe a high fever, bad cough, confusion, and they can't get through to their doctor. So what do? You rush to the ER, which swamps the ER, increases cross-infection risk for everyone there, and burns through resources needed for the truly critical cases.
And that's where a tool like the Dr. Maya concept fits in. It's designed to be that first filter, right in your pocket. An AI that can immediately assess your symptoms, give you an idea of severity, and guide your next step instantly and accurately. It helps spot the real red flags, early sepsis, trouble breathing that need immediate emergency care. But just as importantly, it helps keep the less severe cases safely at home.
So it acts like an intelligent traffic cop for healthcare during a crisis.
Exactly that. By helping sort people appropriately, it cuts down on unnecessary hospital trips, travel, costs. And crucially, it helps prevent those non-critical people from getting exposed to nasty hospital bugs, including those AMR superbugs we talked about. That's a huge public health benefit right there.
But the AI's role goes beyond just individual triage, doesn't it? It has implications for detecting the outbreak itself.
Absolutely. Think about how traditional surveillance works. It relies on doctors reporting cases, lab confirmations, developing specific tests. It's slow, especially at the very beginning when nobody knows what they're dealing with. An AI system like Dr. Maya, processing symptom data directly from the community in real time, has the potential to spot clusters of unknown infections before they spread, not after 1,000 people are already infected. It could provide that crucial early warning.
And this connects to that political angle you mentioned earlier about transparency and trust, which felt pretty fragile during the last pandemic.
This is potentially a really powerful aspect. Because the data flows directly from individuals to the AI, the surveillance becomes inherently decentralized, community-driven. The sources suggest this could act as a check and balance. It could help prevent leaders from concealing the truth about the onset of epidemics because there's this parallel, transparent stream of information emerging directly from the population outside the potentially slower or politically influenced official channels.
And using AI for this kind of detection and guidance, it's not some far-off sci-fi idea, is it? It fits into a much broader trend happening in medicine right now.
Oh, completely. AI is moving rapidly from theory into practice across healthcare. You've got researchers exploring generative AI, things like ChatGPT, to help doctors figure out treatment options for really complex antibiotic-resistant infections.
And can AI handle the sheer volume of data needed for this kind of public health work?
Yes, absolutely. Modern computational methods and AI platforms are specifically designed to handle massive, diverse data sets. They can integrate symptom reports, location data, demographics, whatever is relevant, to predict where AMR is flaring up or where a new cluster might be emerging. AI's strength is synthesizing huge amounts of information much faster and potentially spotting patterns much earlier than human analysts alone ever could. That speed is a massive advantage in containment.
So we started with this core choice for disease X. Do we bet big on the long, expensive, maybe risky R&D path for cures? Or do we prioritize the immediate scalable path of prevention, isolation, and smart AI-driven triage?
I think the evidence we've reviewed strongly suggests we need both, but containment has to be the immediate primary focus. Given the R&D timelines, the potential safety unknowns with accelerated rollouts, and this backdrop of the escalating AMR crisis turning hospitals into danger zones, the priority has to be building robust, decentralized systems now. Systems that can accurately guide people, provide transparent surveillance, and function even when, or especially when, the traditional medical infrastructure is overwhelmed.
It suggests that maybe the most critical infrastructure we need before the next pandemic isn't necessarily another vaccine factory for a vaccine that might or might not work perfectly for everyone. Maybe it's actually a system built on trust, community data, and immediate intelligent guidance. Which leads us to one final provocative thought for you to take away from this deep dive. If citizens are directly feeding verified symptom data into a decentralized AI, uncovering the start of an epidemic in real time, effectively bypassing traditional government health reporting, does that fundamentally change the relationship, the balance of power and transparency between the people and the state when it comes to managing a health crisis?